It's extremely important to recognize the comorbidities that exist in the older IBD patient, and that is the baggage that they carry with them when making decisions regarding therapy. Fecal incontinence plays a major role in our patients. Often it has to be specifically queried because they may be embarrassed to tell you about it, but the idea that the anorectal physiology changes with age is real. There is a reduced evacuation with altered motility. The problem of perineal descent and reduced sensation plays a role, and this is particularly important if the patient is involved with rectal therapy, not only difficulty in self-administration, but also in retaining the fluid.
I find this is very important in my women patients, those with IBD and also many patients without IBD, and it really manifests in two ways. One is fecal incontinence, and often it's a result of damage to this area, or injury to this area at childbirth, but obviously the symptoms come many years later, and I explain it to them that as we get older, things get weaker, and that's why these changes of incontinence can happen later. The other, as you mentioned, the perineal descent, and many patients have a hard time actually evacuating all of the material that's there, and I find this actually even a harder symptom to treat than the fecal incontinence. But they're both very, very challenging, and you're right to ask, because patients are embarrassed and they may not want to admit it, and yet these symptoms are very, very common.
We have been pursuing this with defecography in patients who have this problem, because we're looking not only for rectal prolapse, but perhaps those patients who, after anorectal motility or defecography, may be candidates for biofeedback. Very few are ever candidates for surgery, but if there is a true rectal prolapse that is correctable, then certainly that should not be overlooked.
And I think that's where the history can be important. Do they have fecal incontinence before their IBD symptoms started? Then they may have a pre-existing sphincter or nerve problem. But for many of these, they're compensated with their sphincter injury from prior obstetrics. But then they get IBD and they've got diarrhea on top of it, and they are no longer compensated. So in those patients, sometimes just treating the IBD will treat the incontinence as well. In others, they need specific attention to the fecal incontinence.
And going back to how to detect it, it's often you often require, are you wearing a pad, are you wearing chucks, or something else going on where you're embarrassed, where you have to carry a change of underwear with you whenever you go. And this is something the patients almost never tell you until you actually make the inquiry. Osteoporosis is a major problem, not only in our postmenopausal females, but because the IBD patient can suffer from the cumulative effect of the disease activity, the malabsorption of D and calcium, and malnutrition, and the total additive effect of the steroids or methotrexate or cyclosporin. And with a 40% fracture rate, this has to be addressed, and quite vigorously so.
Yeah, I agree, and this gets back to the comments we made earlier about vaccines and cancer screening. I think we have to remember that bone health is part of our responsibility. And if you look at the recommendations for who should be screened for osteoporosis with IBD, it ends up being a large percentage of our patients. In particular, age is an independent factor that should require osteoporosis screening with a DEXA scan.
I absolutely agree. I think that it's incumbent upon us to get anyone over the age of 60 more than 3 months of corticosteroid therapy, and particularly those who may have continued active disease, that this be done, because it's devastating once they sustain a fracture. There are late-life confounding diagnoses that can alter our therapy. The impact particularly of neurodegenerative diseases, the Parkinsonian patient, or stroke. The impact of depression is becoming much more appreciated these days, not only in the younger population, but also in the older population. And in one study from Canada, this proved to be more of a risk factor for disease exacerbation than even the use of steroids, NSAIDs, or infection in that population. I'd also want to reiterate the need for checking the vaccination status, not only because of hepatitis B in our population of Southeast Asian or Asian patients who harbor this before biologic therapy, but generally the risk of opportunistic infection, and when should the patient start seeking the attention of a pulmonologist or an ID person when they have, say, an upper respiratory infection, which they think is community acquired.
In addition, so I'd say that with the neurodegenerative or arthritic issues that become more and more prevalent with age, that also plays into your decision to use topical therapy. So even if they're not incontinent, they may not be able to give themselves an enema very easily.
It's very difficult extracting data from existing studies because most of these studies have been sanitized to the point where they will not include patients over a specific age or if they have coexisting diabetes, hypertension, or any of the previous neurodegenerative diseases. So it's very hard to make decisions based on clinical trials. Drug-drug interactions play a role, and it's important that the physician realize that as one ages, there's a decrease in lean body mass and total body water. As a result, the volume distribution for drugs decreases, so drug blood levels rise and toxicity becomes a problem. The creatinine clearance decreases with age in almost everyone, but particularly is accelerated in the diabetic and the hypertensive. So again, we're faced with higher, more toxic drug levels, and this may be compounded further with the coexistence of renal disease, hypertension, vascular disease, and the multiple over-the-counter preparations that patients take, which they may not realize have an interface with what they're presently taking.
Agree. And then, again, to make the point we made earlier about NSAIDs, we have to ask patients specifically about supplements, over-the-counter things, because they may not put those on their medication list. Many of them have GI side effects or interactions.
The interaction of drugs used in IBD are really quite significant, and virtually all of our IBD drugs, with the exception of biologics, and that probably is because we haven't had a total extensive experience, will and may interact with many of our present drugs that are used for hypertension, diabetes, or the cardiovascular area. But the one area that is particularly troublesome is the interaction of the IBD drugs with warfarin, because so many of our patients have atrial fibrillation who are on warfarin or have vascular disease where they require this. And almost every one of our medications will either increase or decrease its effect, and that has to be taken into consideration. So what are the take-home points? It's extremely important that we make a distinction between the fit versus the frail elderly patient. The fit 75-year-old playing singles tennis is a totally different animal than one who's brought in by an aide or the walker. With drug decisions, always consider the mantra of starting low and going slow. And one thing we have to remember is you have a perfectly functioning patient who's quite comfortable. Don't destabilize by the risk of new medications that may not have a significant benefit, or particularly in our zeal for mucosal healing, which we know has a benefit to the younger population, we can really trip someone into a significant decline. The risks versus benefits conversation is extremely important, and what we do in our practice is we always have another family member present when we talk to the patient. Don't go it alone. Have the patient there with someone who can not insult them by saying you can't remember, you can't understand what we're saying. But several years ago, we did a very small study in our practice, and we asked patients of all ages, how much do you remember of what we said 1 week ago? It was shocking to find out that it was 10%. Mm-hmm. So show the fact that you are covering ground by having another person present. Remember that symptoms trump mucosal healing, and from the more recent studies that we've seen, show that you care. That sounds absurd, but many patients feel that they are being rushed through their office visits, that they are being seen by ancillary supportive staff and not getting the benefit of the physician's time.
I think those are great points, and especially the elderly patients may need a little bit more time. Mm-hmm. Some of the cognitive functions aren't as sharp as when they're younger. And also be careful about who that other person is, because sometimes the spouse may be even older and less cognitive aware. So I like the idea of having other family members there, especially younger family members who may ask different types of questions or have different memory abilities.
Yeah, I agree. And oftentimes, in addition to that, I will write out in plain English mm-hmm. what the prescription is, how often to take medications. Mm-hmm. I also think it's worth discussing how we communicate with patients what to watch for. We've talked about side effects, the fact that for many of these medications, the risk of side effects is increased in older patients. And I think it's not enough to just say these drugs increase your risk of infection, right. But I think we have to tell them what to watch for. So I say any fever, you should be checking in with me or your primary care doctor. Right. Certainly any cough or sputum production, significant abdominal pain, burning when they urinate, skin rash.
Mm-hmm. You just brought up a very interesting point. For years, when I'm speaking with a patient, we always give them a diet, even though we know diet may not be the critical nature, because one of the most common questions asked of us after we finish a lengthy discussion is, well, what can I eat and what can't I eat? And then on the back of the diet, I will always write out in my handwriting, even though it isn't the greatest in the world, to explain what are the key points we covered. and then we have the secretary who signs out the patient reread my handwriting to them. It's a personalized touch. It may not be terribly important in the light of eternity, but it gives the patient a feeling, well, I've actually spoken with the doctor and I'm going home with something. On behalf of Drs. Pardi and Surawicz and myself, we'd like to thank you for participating in this panel discussion and this educational activity, and we hope that you find this very helpful.